Thank you, Larry, not only for inviting me, but being very generous in giving us the time to discuss this topic that we started discussing yesterday. I don't know, it says I have to disclose that I am getting grants from Sigma Tau and Jazz and Amgen, so I don't know if it's written here. So I will talk about what's the role of transplantation, of asparaginase. I'm still in the previous lecture. And how to do it. We divide it in a way that Matthew will talk about toxicity, although I will say a few things, and Adele will talk about its use in the UK within a national clinical trial. And we hope we'll have a half an hour for the discussion because there's more questions that I think people have. So I divided my talk into does asparaginase matter in adult ALL and the issue of dosing, and I think that's maybe even more important. So asparaginase is incorporated in all pediatric protocols, most adults except hypersensitivity. There is a reluctance to use the drugs, considered to be more toxic than children. There's never been a randomized trial in adults, and regimens without asparaginase show, at least until the pediatrics we use, showed comparable outcomes to regimen with asparaginase. So there's no documentation that it is better. The reason for the reluctance, and I leave it for the next people, is the unique toxicities, and those that are highlighted in red can be life-threatening. There are other toxicities with morbidity, and we raise some of them, and we'll talk about it later. But that's the main reason. But a lot of it is historical. If you look at the incidence of toxicities in the 60s, it is much more common, not much, but more common in adults, but it's still very high in children, particularly the liver toxicity, 50%. We don't see that. And I think that was one of the reasons that adults try to stay away from this drug. Now, you have to understand, this is E. coli asparaginase. It was produced from bacteria, and it lots of impurities. The products that we use today are pure, and they have that certainly will have less toxicity. But this was the problem that, at least in adults, this is the mechanism of action. Really, what you want to do is to deplete asparagine from the serum. Asparaginase breaks asparagine, so there is no supply to the blood cell. The hypothesis that is that the cell cannot make, leukemia cannot make it, it's dependent on the plasma. So this hypothesis is not, I'm not sure that this is the only hypothesis, but the pharmacodynamic effect of the drug is the asparagine depletion. There's patient-to-patient variability because this is a non-essential amino acid, so the levels of asparagine can change based on diet or liver sensitivities, and that might be, and we'll show a bit later, reflect different events in outcome. But there are certainly differences in the level of the asparagine in the blood. In fact, there's also differences in the enzymatic activity in the drug. We have 3 preparations, E. coli, it's almost a day half-life. The Erwinia that is now commercially available, until a few years ago, it was very, very difficult to get. And this is used for patients who develop allergy to any form of E. coli asparaginase, and it has a very short action, and that's why the dose that is given is double, 25,000, not 12,000 that we used to use for E. coli to overcome. This, I won't show it, but this actually, the way it is given 3 times a week, even with this short half-life, the studies in children show that it does provide asparaginase activity continuously stable throughout the 2 weeks. So it doesn't go up and down, it stays stable. And even through the 72 hours of the of the weekend, because we only give it on weekdays. And the pegylated asparaginase, it's a very long-acting drug, less allergic reactions, and it used to be a replacer of E. coli, but it is an E. coli product, so if you have allergy to pegylated, this switches to Erwinia. It also provides, which I think is important, with single dose, a continuous asparagine depletion, and we'll see if it is important. This E. coli, okay, I don't know what, so the E. coli is no longer available, but I know in Canada it is available, so that created some problems in design of clinical trials, but the other two products are available. So is it important? So the first way to look at it, is there any correlation between the enzymatic activity and outcome? There's a little bit, where is it moving? There's a little bit of data. This is a pediatric protocol, actually with pegylated asparaginase, even though it's old, and they combined it with other drugs, but they showed there was some correlation, the numbers are small, between higher asparaginase activity and outcome. The numbers, I'm not so sure, but they statistically was correct. This is, I think, a more reliable study by Meyer-Welser, retrospectively looking at asparagine depletion and outcome. In fact, they didn't measure asparagine. They measured the enzymatic activity and extrapolated it by to asparagine level, and that's an issue by itself. But they were able to show that if you had a better depletion in that study, the outcome was better. So there is some correlation between serum activity and outcome. The second argument is there is a dose response and a single agent activity. So this is not truly a single agent, but it's with 6-MP, but almost a single agent. But you can see you can get a very nice single activity by the drug by itself in children. That's an old study from '79, but you can see there's a clear dose response, and that's actually established the dose of E. coli. And this is not a randomized trial, but this is a recent data from the Germans, showing that if you give 2,000 units of pegylated asparaginase, it seems that the outcome is better. Again, this is compared the same study, but looking retrospectively. So in the middle of the trial, they changed the dose. And so that's the weakness of this. So, and the third argument is any clinical data that suggests that there is any role. Now, we don't have much in adults, and we certainly don't have randomized trials, but there is data from children. And I think this is one of the first papers from '97 that shows that if you gave Vincristine, Prednisone, and asparaginase, by the way, no myelosuppressive drugs, you get a 93% complete remission rate. These are two studies by the CCG, 800 patients. Historically, they were using only VP, 86%, only these two drugs. But it was significantly better when asparaginase was added, and this is the dose that they were given. So there is, at least, this is not randomized, but comparable. And these are the two key randomized trials. So I have to go to the pediatricians. There's no randomized trials in adults. This is, I would say, the landmark study from the Dana-Farber by Dr. Salen that was updated. And what they showed, the hypothesis was that you need to have asparagine depletion continuously for a long period of time. So they gave weekly 25,000 of E. coli asparaginase. Dan DeAngelo talked about this model. And so, and they also got it during induction, but the point is during the post-remission, and those who got it post-remission had a significantly better outcome in a long-term follow-up compared to those who did not have any asparagine depletion. And this is actually it's for non-T cells, and I don't know why it was chosen, but that's the paper one. The second one was done a little later, and this is with a drug. So what it tells you that just changing one drug in a multiple complex regimen has an impact in outcome. And that's one of the problems that we have in ALL. How do you know which drug is important? Is Vincristine important in that complex? But at least in asparaginase, there is data to support it. And this is from the POG in T cells, the same model. They gave it, I think, a little less. Oh, no, for 20 weeks, they see again the same difference in outcomes. So these are two randomized trials. Since then, this is mostly high-risk patients, every randomized trial showed the benefit of asparaginase. Two studies looked at long versus short duration. The CCG 182, when you gave it for 5 cycles, you see a much better outcome. This is the augmented BFM versus PFM that was led by the late Dr. Nachman. And the more recent one, the CCG 91, Pegaspargase given for 4 to 7 cycles as opposed to E. coli, 1 or 2 cycles, clearly a difference in duration and a better outcome. There is data from Dana-Farber that early stopping might have a negative impact, and that's something we'll have to discuss later. And one study talks about maintenance and using the same model, but not in consolidation, but giving it in maintenance. So there's enough data in children to convince that in a package of all these drugs, asparaginase has got a major role. And as I showed the slide yesterday, but I wanted to show, these are not the pediatric inspired, but these are what we have been doing for years. In induction, asparaginase was given, but I personally think it's the post-remission duration of the drug. And only 1 cycles, Hypersensitivity doesn't have it, and some of the old studies didn't have it. So adults really, this reflects the reluctance of using it, because they never added it into the regimen. So in summary, does it matter? I think yes. Single agent activity, dose response effect, correlation between asparagine depletion and outcome. In several clinical trials in children, there was a benefit of asparaginase in a randomized trial. And the big problem was the duration of treatment with asparaginase, which in children was shown that you need actually a longer duration, 5 to 6 cycles, and in adults, it was 0 to 2. There's something that I won't discuss, but I'll just raise it now. The long duration, you have to distinguish between, does it have to be sustained, or it can be given intermittently? And I don't think there is an answer, although a lot of people think that it has to be sustained. So you have to continue. So I'm not sure that is true, and we actually don't use that approach. But that's something that we have to bear in mind. And this is, again, I showed this yesterday, the pediatric protocols, all of them have pediatric doses of asparaginase, and I will show today some of our own data to really make some very specific points. You can see the outcomes, we talked about it, have improved. So I think asparaginase matters. The second question is how to dose it. And this is very important because there's lots of details. The dose, the interval between the dose, the route of administration, IV and subcutaneous. Another thing, the synchronization with other chemotherapy drugs, especially for pegylated asparaginase with long-term activity. And then resistance with neutralizing antibodies that can be silent without a hypersensitivity reaction, and you're giving the drug if you don't measure it without activity. So the package insert, based on a pediatric study, not in adults, says that the dose is 2,500 units, so it should be units, I'm sorry, it's not milligrams, it's an enzymatic activity per meter square, and it says you cannot give it more frequent than 14 days. So that was interpreted that you should give it every 14 days. And that's not said there. And I think that's been done by the Dana-Farber in children. They're giving it every 2 weeks based on that. And in children, it might be possible to do it. So first, the dose. This is an old study that actually was a phase 1, and I had difficulty finding it and even copying it. And they showed in adults, actually in solid tumors, and they gave it IM, and they showed that actually the optimal dose is 2,000. Other doses might give you, they measured actually asparagine, the amino acid, they are less effective. They have some activity, but not as good. So that was the point, that 2,000. But look how it takes a little time. It takes a few days to get into this level. So we repeated the same. So we did our own pharmacokinetic because we believe that you should give it IV. And if you give it IV, maybe you don't need 2,500, and we gave 2,000 and wanted to check if that's adequate. So this is a study done with Dr. Avramis. I'm so sorry he's not here because all this pharmacokinetics is his work, and I mean, he's actually the person that brought me into the field, and unfortunately he can't be here, but I just want to give credit to him. So it was found that we have a very long half-life, a little longer than children, but in the range. And this is the enzymatic activity, very long, almost a month. We also had the opportunity to check the asparagine. That's very difficult, and I, again, give credit to Vas. So first, I didn't put it here, on 2 hours, there's no asparagine in the blood. So if you give it IV, it works very fast. 14 days, yes, everybody has the enzymatic activity, but everybody still has it in 3 weeks and half have it in 4 weeks. So the drug is in the body and the activity is there for 4 weeks. This is something we did on the side, and it's kind of in the middle of the study, but I thought it was nice to show. In parallel, we checked antithrombin 3, and we saw it dropping exactly corresponding to the duration of the enzymatic activity. So everybody has antithrombin 3, and I guess we'll talk a lot about thrombosis as a complication. So from this study, we concluded that it's 2,000. You can give it IV. There is no, the fear of giving IV is disappeared, and I actually had to go to Dana-Farber and convince them that you can do it in kids, and I think the kids are very happy that they don't get it IM anymore. So the issue of IM is really is not an issue. In fact, theoretically, it might even be worse. And it's, so we have always given it IV. So all the data that I'll show you is for IV. And it depletes asparagine for up to 4 weeks. I also found, we compare it to historical data, that it is safe as 14 doses of E. coli asparaginase. But we concluded that the interval cannot be shorter than 4 weeks, because if you'll give it after 2 or 3 weeks, there is a good chance that you will be giving the drug when the previous drug is still active, and you will see the toxicity is still present, and you will increase toxicity. And there are studies in adults that have given it every 2 weeks, and they saw a lot of toxicity. There are still studies that move from 2 weeks to 3 weeks. In my feeling, you cannot give it more or less frequent than 4 weeks, and the argument is here. And that brings the question, because if you want to give it every 3 weeks, you want to push the sustained activity. And so you believe that that is important. There's no data for that, but you increase the toxicity. We are not sure that this sustained activity is important. We believed in the prolonged, and therefore, when we did the subsequent study with multiple doses, we used it for more than 4 weeks. So sometimes it was less, sometimes it was more. So this is the study that recently was published, multiple 6 doses. We actually took CCG forgot to put the number, 1862, the one published by Nachman. We did a few changes. Again, it was pegylated asparaginase, exactly like we gave. This is our induction. I'll talk about it in a few minutes. And then gave 6 doses, and it was double. Now, the pegylated asparaginase was given at the same doses that the pediatric gave the E. coli. It was 8 doses. And other things is, there were some other minor changes. This is basically a pediatric protocol. And I will focus on these 2 cycles to show you some aspects of synchronization with other drugs. So this is the induction, and actually the first study was done like this. We give the Dauno-rubicin at the 3 first days, and again, this is the details of the dosing. A lot of protocols, and even the 10403, the new studies are going to give it once a week, although a lower dose. I'm not sure this may be too much of a dose, but that's what we're giving. And asparaginase is given 2 weeks later. And the idea is that by this time, the myelosuppression from the Dauno-rubicin, which is the only non-myelosuppressive drug, will start to go away, and then you come with the toxicities of asparaginase. You know, in cancer, we like to give drugs with these toxicities at the same time. But if you have drugs with severe toxicities, you don't want to give them at the same time. So you don't want somebody with pancreatitis and sepsis because of neutropenia. So that's the synchronization that we did. And what we were interesting to see is, and we used the same dose, and this is the data. And so just some data. The complete remission rate was 96%. Most of them went into remission after 4 weeks. We didn't do the MRD, but a lot of regimens, it takes 20%, it takes 8 weeks. So we think our current study is looking at MRD. And we saw that the recovery of the marrow was much shorter than an induction of AML, a median duration of 17 days. It's much shorter. And by 3 weeks, we send the patients home by day 18. Early death was very, very low. So it is possible that because of this synchronization, we were able to avoid spreading the Dauno-rubicin, and actually it would be difficult to give it on day 22 because you might have liver toxicity at that time from asparaginase. There is a problem of Vincristine sometimes because you might not be able to give this Vincristine. So these are the elements of the induction or the details of the induction. The second synchronization, and we discussed it yesterday, is with asparaginase, with high-dose methotrexate. So we didn't take the Capizzi approach, we took the high-dose approach, and I know that the children looked at it. The reason was we felt that preventing CNS disease was critical, but we knew the Capizzi concept that you can't give asparaginase here, because with its long activity, it will block the methotrexate here. And that was the question yesterday. So this was given always after the second one. This is a very easy course. You don't get any neutropenia, nothing. And the side effects we'll see only of the pegylate. And that was given twice in the course. This is what you saw yesterday. I don't know if it's updated, but that's what Eric shows, the comparison with high-dose methotrexate. But the Capizzi with the pegylated asparaginase, that was, the results were not as good, and you can do it with E. coli, but maybe the pegylated asparaginase blocked the methotrexate activity. And so I think this is the 10403, and I would like to hear comments about it. I think there needs to be some modifications. I think it's clear that the dose should be reduced to 2,000. I think the ECOG has reduced it. I think we can take the IM. The intervals here are too short. It's a 20-day interval. You might run into toxicity of the previous dose. And this is one of the main problems. Choosing probably the wrong arm. That was in children shown to be the less important one. So this is, I think this has to be changed to to higher dose. Otherwise, that's a good pediatric approach, but I think modifications. Also, I'm not sure that giving, as I said, the myelosuppressive drug, I think it should be given at the beginning. So this is the study that with the multiple drugs, our second trial, 51 patients, a medium age of 39. We went up to age 57. It was 55, but we went up to 57. Two-thirds were high risk. We use the ECOG MRC classification of high risk. We didn't use MRD. 76 were in the LA County Hospital. So it is different to treat patients in a public hospital. It's easy, but also different. Most were Latinos, so that's something to bear in mind. And we couldn't do many bone marrow transplants because most of the patients didn't have the insurance to do it. So the plan was to give them 6 doses, but only half actually got the 6 doses. So we're interested, is it possible to give so many doses? And I think the 10403 didn't need to tell us how many people got the dose. In fact, is it more dosing than the old studies which they gave E. coli? I mean, I'm not sure. So half got 6 doses. The average number of doses was 3.8. Now, what we saw, that stopping the drug for toxicity was only 20%. So the other patients, the drug was not completed because either they failed, usually death in consolidation or relapse while they were, and the others because they went to transplant, so they were not eligible to continue, and there is one who decided to leave the study. So there is, you can't give all the 6, but many times it's not because of toxicity. And we'll talk about toxicity later, but this is our toxicity from this study, 51 patients, 173 doses. And this falls similar into the range that we see in children. A very low rate of allergy. Every dose of asparaginase is pre-medicated with hydrocortisone. And I think Dr. Advali talked about this, reducing the allergic reactions. We have seen quite a bit of deep venous pulvosis. I think we are underestimating in this study because I'll be seeing it more. And the triglyceridemia is also underestimated, so we didn't measure it so much. I think it's much more common. But this is the thing that worries everybody. And this is the high rate of hyperbilirubinemia. You don't see it in children. So 31 patients had hyperbilirubinemia in 13 doses, and these are grade 3 and 4, and transaminitis in nearly everybody. And I know I gave slides of duration of that to Matthew, so maybe he'll show them to you how long it was. I'll just summarize those slides. But what we saw, there was no liver disease. We didn't see any encephalopathy. It was a problem in going to a bilirubin of 10. Everybody's worried, but it didn't cause a problem. What it did cause is that it sometimes, if it was long, it delayed the subsequent trial. So you had to give less. So we planned it not, for example, not to give anthracyclines that it will fall in that. So that's another synchronization. The other thing is we didn't stop giving the drug, even though there was a hyperbilirubinemia. And if Eric will show it, the subsequent doses did not necessarily had liver. Only half of them developed, or some didn't develop even a grade 3 or 4. They might have developed a grade 1. So we still continue giving it, and we don't see this as a big problem, at least from our data. And this data will accumulate. And this is just to show you our overall survival. Is a little bit lower than everybody reported. It's a long follow-up, and it's also the nature of the patients. They're very low socioeconomic, and there was a lot of issues with compliance and management toxicities. So this is unpublished data, and please don't copy it. I asked Len not to publish it because it's the first time I'm showing it. So we had some samples, and unfortunately, after I left USC, they lost some, but I managed to salvage. But I have a very brave lab technician. So we tested 43 patients, 61 doses. We found a very high rate of antibodies. Now, you have to remember, our study was heavy on steroids. Everybody got prednisone, hydrocortisone, and usually the protocol was such that they got a steroid after the asparaginase. So the question, were we masking it? Maybe masking. So most of them were silent antibodies. So they didn't have an allergy. But 2 of them had an overt allergy. But what we saw that 8 of the 11 patients that had some kind of allergy, even the mildest, had an antibody either before or afterwards. Now, you have to understand, this study was done to collect samples after every dose. That never happened. We wanted to so it is possible that we missed the antibodies when they actually got the asparaginase, because we couldn't correlate it. We were not able to get the samples, and a lot of samples were lost. But what was more interesting, that at the same time we measured the enzymatic activity, and it was not neutralizing. You see here, only of the 26 patients that had an antibody and we could measure the activity, the activity was more than 0.2, which is the most conservative level that correlates to asparagine. We think it's even 0.1, but even 0.2 at that day 14, which is the time that at least we wanted to be there. So the conclusion from this is, we'll get back to it in a minute. So a summary of the talk. So the dose, we talked about it, the interval, the synchronization. We're not sure about the impact of the discontinuation. There was a number of patients that did discontinue and didn't go to transplant. And there is a lot of fine-tuning that I think we need to do, and I suggested also in the national trials. The most common toxicity is grade 3 or 4 liver. I would add also thrombosis, and we'll discuss it later. It is long. It's mostly after the first dose, not necessarily recurs after subsequent doses. And the question, what is the impact of it by delaying? We had some patients that we had to delay the next cycle, and that's having an impact on outcome. So we don't know that. The antibodies are common. It's mostly after the first dose. I think that is a bias, because after the first dose, we measured the most. Right? So it's because it was the beginning, and then I think we became a little sloppy. Most are silent, but occur before or after overt hypersensitivity, and only 8% had a higher asparagine cleavage. So they were not blocking the drug. So that is important. So this brings me to a few tips, and then to some questions. So these are my tips of using asparagine. First, I would follow very carefully these guidelines. This is a very long paper, but there is a table. And it's a consensus paper, and you will see different opinions. So it's not a clear-cut recommendation, but at least it gives you all the data that you can read for yourself and judge. Hypersensitivity is clear that you have to give hydrocortisone pre-medication, early diagnosis. So we think with pancreatitis, the problem is not the pancreatitis, but the severe part, the one that you can die of. And we found that if you catch it early, it disappears, so it doesn't get into those severe ones. Thrombosis, what we do is we don't give cryoprecipitate, at least let it go to 50. There's no bleeding, if you notice. And one of the reasons is that the cryoprecipitate has a lactate factor 8, and the problem is thrombosis, and we are increasing the problem. And I think there is a retrospective data from USC. I don't know if Aldous is here, and I think he shows that the thrombosis was more in patients who got this. So this is, we'll talk about the thrombosis. We give much more gamperosil for the hyperglyceridemia. We stop it only for pancreatitis. Hypersensitivity, we switch to Erinia. That is now, so now you can continue giving the entire 6 courses if you have an antibody. We continue even if the patient has a thrombosis on anticoagulation. The package insert says to stop it, but we found that it is very effective. So the questions that I think are not answers: do we need to measure the level and adjust the dose? We said it's 2,000, but there's variability, and that's important both for activity and toxicity. Do we need to check antibodies routinely? There are some patients that have neutralizing antibodies, and the drug is not working. So that's a question. The best time to check if we do it is after 7 days. I think that's the pediatrics, and also our data shows. Is there any activity or any benefit of lowering the dose in elderly patients, which is done to reduce toxicity? And I think we need to work, even though it's not a major, it is a clinical problem. It's not a fatal problem. But still, I think we need to prevent or reduce the liver toxicity. Thank you.